Hello, my name is Zilan Ding, and in this presentation, I'll take the role of a decision consultant. I've been asked to analyze a difficult medical decision for a close friend of mine who has recently been diagnosed with heart disease. My goal is to help her understand her option and provide structured advice using formal decision analysis tools. We'll explore how tools like decision tree and influence diagrams can help support better choice. So let's begin by identifying the key elements of decision using the WIC2 framework. The decision maker is my friend, and her fundamental objective is to maximize her quality of life. She has two alternatives, like undergo bypass surgery or not. If she chooses surgery, the outcome is uncertain. It could lead to a full recovery or result in death during the operation. If she chooses not to have surgery, she faces a shorter life with gradually worsening health. So each decision path leads to a different consequence, and these consequences are what we will evaluate next. To better understand the decision and its possible outcomes, we can use an influence diagram. In Part A, the diagram includes a decision node and representing the choice between surgery and no surgery, a chance node showing the uncertain result of the surgery, and a value node representing the patient's quality of life. And the arrows shows how these elements are connected. The decision itself directly affects the quality of life, especially since no surgery leads to a non-decline. And if surgery is chosen, the final outcome depends on how it turns out. So both the decision and the surgery results together shape the patient's quality of life. Now we've seen the influence diagram, so we can also look at the decision tree for the Part A. The Part A decision tree is very clear. The patient faces a clear choice like have surgery or not. If she chooses surgery, there are two possible outcomes: a small chance of dying during the operation and a high chance for full recovery, leading to a longer and healthier life. If she chooses not to have surgery, the outcome is certain: a short life that gradually gets worse. The structure here is quite simple: one decision node, one chance node, and three possible outcomes. And because the risk of death is low, so while the alternative is guaranteed decline, I think this framing makes surgery look like the better option. But that changes when we hear from the second physician, who adds a new possible outcome to the surgery path: complications. In Part A, we only consider two outcomes after surgery: a high chance of full recovery and a small chance of death. However, the second physician introduced a third possibility: complications. This leads to a second layer of uncertainty, where the patient may still recover, face long-term disability, or die after painful treatment. So how does its new structure change the influence diagram? Let's take a look. We have two chance nodes now, surgery outcome and complication outcome. The first chance node represents whether the surgery leads to full recovery, death, or complications. If complications occur, the second chance node determines whether the patient recovers, becomes disabled, or dies after treatment. These two levels of uncertainty together influence the final value, the patient's quality of life. So now let's build on that and look at the decision tree for the part B. The structure is more detailed now. If the patient chooses surgery, the outcome is no longer just recovery or death. Instead, complications are introduced as a third possibility, and they lead to even more outcomes, like full recovery after treatment, disability, or death after suffering. So, surgery path now has multiple layers of uncertainty, and each branch leads to a very different quality of life result. To evaluate this outcome more clearly, we assign a score to each one. This scale includes all possible outcomes of the decision, whether to have surgery or not. I assign each outcome a score between 0 and 100, based on the expected impact on the patient's quality of life. For recovery with no complications, it's scored at 100, and death during the surgery is 0. Intermediate outcome like full recovery after pain, gradual decline, disability, or pain, then death in between. These scores let us compare decision paths using a consistent, interpretable metric. Let's see how these scores affect our view of the decision in both scenarios. In part A, the structure was simple. The surgery had a high chance of full recovery and only a small chance of death. With that framing, surgery clearly seemed like the better choice compared to a certain decline without it. But in part B, things become more complicated. Once we include complications, the outcomes of surgery vary much more, from full recovery to long-term disability or death after suffering. In my scoring model, I assign no surgery a score of 50. Some surgery outcomes like partial recovery or death after complications fall below that score. This means that surgery no longer clearly dominates. The better option depends on the patient's value. If she is risk tolerant and prioritize the chance of full recovery, surgery might still be worth it. If she is risk averse or fears long-term suffering, no surgery could be a more acceptable path. So, from a decision analysis perspective, there's no single right answer. It depends on how the patient with risk, suffering, and the quality of life she hopes to maintain. That's why how we structure decision and which outcomes we considered really matters. Thank you.